Arteries and veins are directional terms. An artery takes blood away from the heart, and a vein will bring blood back to the heart. It has nothing to do with whether the blood is oxygenated or deoxygenated. It's a directional term. So in the pulmonary circuit, the arteries take blood away from the heart to the lungs. That blood happens to be deoxygenated. It comes back to the heart as oxygenated blood through pulmonary veins. The systemic circulation brings deoxygenated blood back to the heart. Then sends that to the lungs, comes back oxygenated, and the aorta takes the oxygenated blood out to the tissues. When we sever an artery that is peripheral, it will spurt bright orange, kind of the color of the plastic on the chair, blood out. And that's oxygenated blood. We rarely damage a pulmonary vein with an injury, but we could. And if we damage a pulmonary artery, it would bleed blue. And if we damage a pulmonary vein, it would bleed red. We just cut, if we're trying to commit suicide and we're kind of chicken because you don't like pain, we cut our wrist. We don't cut very deeply because it hurts a lot. You're going to have oozing blood come out, and that's oozing venous blood, deoxygenated blood. If somebody sees that and bandages you up, no problem. If you just sit there forever and watch yourself bleed, yeah, you probably die, but it's going to take you a while to lose enough blood to actually do any damage. So, kind of graphic way to introduce you to arteries and veins, but the veins will usually be superficial, so what you see under your skin, it's not going to be arteries. It's not what you're going to cut when you cut your wrist. It's going to be veins that you're going to cut when you cut your wrist. If you cut deeper, you will get to a point where arteries and veins are running together. If you get down to the bone, you're going to cut through arteries and veins. You will know the artery because you got to cut a lot harder to get through that vessel wall. It's full of a lot of smooth muscle, so it's got a thick wall called the tunica media. This will be primarily smooth muscle, and on the inside it will be lined by very smooth endothelial cells, and then a little layer of loose connective tissue. And in this case, this artery has elastic fibers that are condensed to form a membrane. It's called the internal elastic membrane. And then there's another one, the arrow goes a little bit long, it's out in the adventitia, but right in this area you'll have another bunch of elastic tissue kind of bunched together. But then you'll have elastic running throughout the smooth muscle as well. So this would be an example if you had all of this elastic tissue in an artery, it would be your aorta. It's a large elastic artery, and it's designed to conduct the blood away from the heart. It's not designed for distribution, so it's got a lot of branches that come off it that will go to specific parts of the heart. Those will not have the elasticity that the aorta does. They're designed to get the blood out to various parts of your body. So you can still have arteries, but not with all this elasticity to them. Those will have smooth muscle, and they're referred to as muscular arteries or distribution arteries. The outermost layer is called the tunica externa, but it doesn't really tell you anything except that it's the external layer of the blood vessel wall. The better term is adventitia, Adventitia is a descriptive term that tells you this is connective tissue. It's going to anchor the structure, in this case the artery, to other structures in the area. So if it's down by the bone, the adventitia of the vein, as you see here, the adventitia of the vein, the adventitia of the artery join together, and the artery and vein are stuck together. So they're not going anywhere. That adventitia will also attach those structures to the bone, and they will also attach the artery and the vein to nerve and also lymphatic vessels. So deep next to the bone, you have nerves, arteries, veins, and lymphatics, those four vessels running together. You won't see, unless it's filled with fluid or filled with fat, you won't actually see an open lymphatic vessel. As soon as you section the tissue, fluid comes out and that vessel collapses. But you will see the lumen of the artery. It will generally be rounder than the lumen of the vein because of all that extensive smooth muscle in the wall. That smooth muscle will contract when the specimen dies and squish the blood out. So it's very rare that you actually see blood cells in an artery's lumen. The vein, not having as much smooth muscle, doesn't contract as much, tends to collapse and form an irregular shape on the slide. And because it doesn't contract as much, it doesn't push all the blood out. So you usually do see blood cells in a vein. This happens not to have blood cells in it. So if you look across from the artery to the vein, the large vein has all the layers that the artery has, minus the majority of the elastic connective tissue. There is a very thin layer of elastic in some of the larger veins like vena cava, but they don't have all the elastic around the smooth muscle, and they don't have an external elastic layer. They have adventitia, which is the tunica externa. They have smooth muscle, which is the mid-media. And then they have identical endothelium and loose connective tissue under that forms what's called the tunica intima. It's scalloped on this side. The endothelial cells are scalloped because the elastic recoil of that internal elastic lamina. It's like elastic when you stretch it and then let it go. It goes back to kind of scallop shape to it. This, if you're in lab, you're going to see this, and I will post it on Laulima for you. But this is real artery, real vein. Here's the adventitia, connective tissue that's anchoring the two vessels together. This is the lumen, this is a lumen. This lumen is more irregularly shaped. This is nice and smooth and round. You choose the round side, look carefully at the wall. Is that wall thicker than this wall? Yes, it is. That confirms you're on the arterial side, and this is the venous side. So coming back to this again, you look at the smooth muscle that makes up the majority of the individual walls without adventitia taken into play. The thickness of the vein is less than the thickness of the artery. So where does the adventitia of the artery leave off and the veins adventitia begin? You can't really section that out. So if you come back to the real blood vessel again, you can't exactly tell whose adventitia belongs to who. You cut it down the middle, but you don't know for certain where the arterioles adventitia leaves off and the veins adventitia begins. When you have very large blood vessels like that, you also have out here in the adventitia, and you can see little examples of it, is that you have these little blue squiggles and the little red squiggle. Those are implying, trying to tell you that there are blood vessels in this adventitia. When you have big, thick-walled vessels, there's only two ways that the cells in the wall can get nutrients. By diffusion from whatever is in the lumen, and then if that wall is too thick for diffusion to get nutrients to the external layers, then blood vessels will develop on the outside that will provide nutrients and oxygen for the external layers. So these big, thick muscular arteries and your elastic arteries, they will have what's called a vasa vasorum. And that translates to mean you got blood vessels to the blood vessel. And you also have nerves that will help to control the vasoconstriction, vasodilation there as well. The connective tissue in this area, you're going to find nuclei of fibroblasts. And then in here, a lot of smooth muscle. And same thing on in the adventitia for your veins. You'll have vasa vasorum there as well for the big veins like your vena cava and your larger veins in your upper and lower extremities. And if you have an old text, the Martini's, I think up to 7th edition now, if you have 4 or 5 or 6, I don't believe he mentions the thin elastic lamina in the veins. 7th edition, maybe 6th, but 7th he does mention that there is elastic tissue there. But it's very thin elastic lamina. This is much thicker. And you actually can see it in a lot of arteries. So vasa vasorum. This is the same slide that I showed you earlier, just across the way to another side of the arteries wall. So here we've got the scalloped border of the tunica intima, and then the tunica media, and now we've got vasa vasorum. And we've got veins. How do I know it's a vein? Because it's collapsed, it's irregularly shaped. And so big veins that are going to smaller veins that will then that will be taking blood away from the surface. Hard to find artery there. Got a lot of adipose in this adventitia. Why would you have so much adipose around the artery? Protection. Yes, padding. Protection. Good. Now we have kind of a flow chart telling you we start at the heart. First blood vessel to leave the heart on the arterial side, systemic circulation side, is this huge elastic artery, and that's the aorta. It will ascend, it will arch, and then it will descend down through the abdominal cavity. When it gets to the pelvic region, then it's going to divide, and it's no longer going to be elastic artery. It's going to turn into a muscular artery. So what it loses is the internal and external elastic lamina that are found in the elastic artery. The aorta is a conducting artery. It's getting the blood to the location where the branches that are muscular arteries will then take the blood out to particular parts of the body. So here we've got muscular arteries branching off the arch of the aorta, and then down as you go through the thoracic cavity, more vessels will branch off. Go to the abdominal area, more vessels will branch off. Get into the leg, you'll have more division. Eventually, you're going to, when you get out to the tissues, these muscular arteries will divide many, many times and form smaller and smaller muscular arteries, and then end in what's called an arteriole. Arteriole, you're not going to have very identifiable adventitia. There is connective tissue anchoring it to structures around, but it's sparse, and so you don't have stuff that you can dissect out and say that's adventitia. It's just probably part of the basal lamina and some connective tissue associated with the smooth muscle layer. And generally there's about one layer of smooth muscle around the tunica intima, and that's all you get in an arteriole. But that smooth muscle is able to constrict and it's able to dilate, and in certain areas it's going to be condensed and actually be able to constrict the blood flow from an arteriole into capillary networks. So you can bypass capillary networks if that tissue doesn't need oxygen and take the oxygenated blood to some other tissue that needs it. Types of capillaries, generally broken down into continuous capillaries, which means they're not very leaky. What gets out of them isn't going to be flowing through by osmotic drag or past the cells, the paracellular, meaning going through the junction of endothelial cells. The fluid that crosses and goes out is endocytosed on the luminal side of the vessel, and then modified, and then exocytosed on the interstitial fluid side of the blood vessel. So you endocytose from the lumen, modify it through the capillary, through the endothelial cell, and endocytose it out here. So that would be the continuous capillary. I just have my questions in the way there. You have continuous capillaries that are pretty small. You've got a 30 micrometer arteriole, and now you're down to about 8, so about 4 times smaller, 3 times smaller. You then have these types of capillaries where you want to control what gets out, and when you want to control the amount of water that leaks out. So for example, your lungs. You don't want fluid leaking out very quickly from the blood vessels, because that would be then diffusing down a gradient into alveoli that you're trying to keep dry so that you get good gas exchange. If your alveoli fill up with water, then the gas has to diffuse through the water and then the diffusion barrier into the blood. So you have continuous capillaries in areas that you don't want a lot of fluid leaking out. You don't want a lot of fluid leaking out into your brain tissue either. You want to control what gets out there. So in the areas that you're not having hormones go across the capillary wall in the brain, you have continuous capillaries to kind of control the amount of fluid that gets out there, and also other things in the blood selectively deleted from getting in contact with the brain. However, in the hypothalamus, in the pituitary, and in the brainstem, where you need access to the blood to monitor things that are in the blood, or have hormones leave the capillary, or hormones enter the capillary, you have what are called fenestrated capillaries. Fenestra are windows, and they're in the endothelial cell walls, and they're also between adjacent endothelial cells. There's big holes in the capillary, and this will allow large molecules to get across. and it will also allow a lot of fluids to get across. So where you have hormones that need to get into the capillaries or get out of the capillaries, you'll have these windows. And then in the kidney, where you're wanting to filter things that you want to get out into the urine, you also make it relatively easy to get out of the capillary. And then you set up barriers outside the capillary that will restrict things getting into the tubular fluid. After you leave the capillary, you have what are called post-capillary venules. And these are small little vessels that are channeling the blood into larger venules, which then will start to join together and form medium-sized veins and then your large veins. These post-capillary venules are noted in a lot of tissue for being even leakier than your capillaries. So this will be important should you get into diagnosing edemas and fluids that are in tissues that aren't supposed to be in tissue. You start to look at chemical effects on these post-capillary venules and how leaky they are becoming to the fluids. It may not be the capillaries problem, it's the post-capillary venule that's actually leaking the fluids out. Yes.
Is that the same thing as a sinusoid?
Sinusoids can be a capillary sinusoid, it can be a venous sinusoid, they can be small, relatively small, but they can also be big. So a sinusoid, you have to look at the vessels in that area, and a sinusoid is going to be, or a sinus is going to be a dilated something. Yeah. So we'll talk about the sinuses and sinusoids coming up in the later part of this chapter. Yeah.
Quick question. It's about the figure 22.1. It shows that the smooth muscle of the vein is actually as well as in the adventitia.
Adventitia?
Yeah, adventitia.
Smooth muscle, there's a little bit of smooth muscle in the adventitia.
Or vein, right?
For both arteries and veins. But it's primarily, for your test purposes, it's in the tunica media. This is an example of fenestrated capillaries. The endothelial cells themselves have windows in them. So this allows for fluid to go directly across from the lumen to the interstitial space. And in this case, this endothelial cell is also endocytosing and then modifying and then exocytosing out to the interstitial space. So fenestrations, they allow for a lot of water to go through. Anything that is small enough to get pulled without water pressure going out will also go through the fenestrations. Anything that's lipid soluble doesn't need an opening in the endothelial cells to get through. It just goes through the plasma membrane. Gap junctions are examples in the heart of fenestration, but these are different kinds of fenestrations than the capillary fenestrations. So paracellular route, this would be transcellular route. We have endocytosis, exocytosis through the cell. So trans across the cells. This is para or next to. And these routes can also be very leaky to water and ions and other substances. Depends on size and what it can fit through. When you get from the arteriole out to a location of a capillary bed, you have two options. Either let the blood go into the capillary bed. To do that, you've got to open the smooth muscles that are acting as sphincters, as gateways to the capillary bed. Or you keep those closed, and then the blood will bypass the capillary bed either by arterial venous anastomosis, so two blood vessel connecting two blood vessels, or through what's called a thoroughfare channel, and these are larger than capillaries, so they're called metarterioles. The little channels out here, these are your capillaries. They're smooth muscle sphincters that will control blood getting into the capillaries from the metarterioles, as well as entering the main metarteriole as well. So there's a lot of options or opportunities to let the blood go elsewhere when you get out to metabolically inactive tissue. So all these little round things pointed to as precapillary sphincters, they're up here as well. And anywhere you're going into one of the capillary channels, you're going to have these smooth muscle sphincters that can close that channel down. Where you have white spaces, that's where your tissue cells are going to be located. If the tissue is not consuming oxygen and not producing CO2, then these sphincters will stay closed. Those are usually under chemical control, meaning if you produce CO2 or there's a deficiency of O2 out here, those will dilate and blood will flow out to the tissue. So the tissues are really under their own control whether or not they get blood or not. They're not metabolically active, don't have high CO2, haven't consumed O2, and produce other metabolites that will dilate the smooth muscle, then the blood just bypasses the tissue. If it's going through the tissue, it's going to be more oxygenated at the beginning and less oxygenated at the end as the tissues suck the oxygen out. This will have higher CO2 but lower O2. And then this is just a picture of capillary bed in living tissue. They've probably filled this with some kind of latex or resin so that it will keep the arteries and arterioles and capillaries open when you section the tissue, and they don't close down. Okay, clicker question. Okay. What is true about that vessel? Is it a distribution vessel? Does it have an internal and external elastic lamina? Nobody's going to answer. Yes. Okay. It has scallop border. So obviously it has an internal elastic lamina. It's got an internal, it's got an external. Is it involved in O2 and CO2 exchange? Not exchange, only capillaries. The wall is too thick for O2 CO2 exchange. So is it a distribution vessel if it has internal, external elastic lamina? No, it's not. So distribution vessels would be muscular arteries. They would not have that internal, external elastic lamina. Valves, you only have valves in veins. The advantage to being on the arterial side of the circulation is blood can flow in any direction in an artery. And this is very important. We mentioned this in the heart, that if you have a blockage of a coronary blood vessel, but you have an anastomosis with another artery, blood can flow from another artery through the anastomosis and get back to the area where the blockage is. So it's no lack of oxygen delivery to the tissue, but maybe some decrease because you've already taken oxygen out of the arterial blood from that due to the intact artery, non-blocked artery delivering blood to tissue, and by the time it gets back up to the point where the blockage is, it's already sucked some oxygen out there and picked up CO2. So it is advantage that an artery does not have valves. Most of your veins also don't have valves. It's just the medium-sized veins that are in your upper extremities and your lower extremities that are fighting gravity. So you stand there and your arms are down by your side and your feet are below you. You need to have something aiding the venous return towards the heart. And the valves help this by, just like in the semilunar valves, they have 3 cusps. If blood goes above them and the pressure is taken away, the blood will want to go back below the valve, but the valve's cusps will trap the blood and they will snap shut. So here we've got a couple of valves. They're closed here. That means that blood has come back and filled the cusps and snapped them shut. The reason blood is going backwards is because the skeletal muscle has relaxed. Here, when the skeletal muscle contracts, compresses the medium veins and generates pressure, and then can open the valve above and push the blood through that valve up one segment. As soon as it relaxes, the blood wants to come back, but it will get trapped above the valve by getting into the cusps and snapping it shut. The blood that leaves this point is creating a negative pressure that will suck blood past this point. You got other muscles down here. If you work your feet, if you're on an airplane and you're stuck in the window seat and you can't get out, you need to get your blood, your feet are starting to swell and your shoes are feeling tight, then just start working the muscles underneath your feet and working your toes and your feet muscle, and those will squish, they will press blood on the blood down here and create pressure that will eventually get it up to a valve, and then the valves will help to take the blood up section by section. Once you get out of the legs and into the abdominal region, you still have some veins that have valves, but as you get towards the big vessels like the vena cava, as soon as you enter the vena cava, those large veins don't have any valves anymore. But their blood is getting sucked into the heart by atrial diastole. So you have negative pressure in the atria that's sucking blood from the inferior vena cava into the right atrium. Once you get the blood from the upper extremity into the chest region, then it's downhill. It's with gravity to the heart. So you don't need to have valves either in the veins in the head. They're draining via gravity. And then the larger veins in the chest region also don't have valves because they're draining usually with gravity towards the heart. And even if you stand on your head, you still got the heart's negative pressure to help with getting the venous blood back to the heart. If the valves close properly, then they prevent retrograde blood flow. Everything is moving towards the heart, which is antegrade or forward flow. But if the valves get damaged, then you got something that looks like this. This is called varicose veins. This is one of the worst examples I've seen of it. Now, don't get freaked out by the blue there. I'm assuming, yes, they colored the veins, I'm assuming because they're going to operate on that leg to remove these varicose veins. They're very tortuous, which sounds just like what it is. They've been tortured. Their valves are primarily incompetent. So anywhere you see an indentation, that's probably where a valve is still working, but blood has pooled above the valves, and when you stand up, then the vessels are more prominent because now gravity is allowing the blood that is above an incompetent valve to work its way back till it finds a competent valve. That poor competent valve has more blood above it than normal, so the vein starts to dilate. And since these are superficial veins, then the skin is now stretched out. So veins are distensible. They don't have as much smooth muscle. They can't constrict efficiently, but they can stretch efficiently. So they're usually containing about 8 times more blood on the venous side than a parallel artery that's right next to it, traveling together. Veins are often referred to as capacitance vessels because they store blood until you need them. Most of the blood, we'll see a pie chart, most of the blood is on the venous side, not on the arterial side. So these varicose veins are due to incompetent valves. If you have incompetent valves with blood pooling in the leg region, you oftentimes get clots that form. And especially if the muscles are weak and you look at this person's legs, their lower extremity is not very well developed. Their anterior tibialis is kind of flat looking. The calf is more swollen than it is muscularly defined. So without muscle development, then the blood is tending to pool more and clots form. The superficial clots are not too worrisome because the veins themselves don't have a direct line to the heart or to the lungs. But this can cause excruciating pain in the lower extremity. It sort of feels like daggers, ice picks jamming into that area. If you touch it, it's really, really painful as well. So you treat superficial phlebitis either with the clot busters, the high doses of aspirin, which has its own side effects, but this usually isn't a problem. But if the pooling and the clots form in deep veins, those veins have direct line to the heart and the lungs, and deep vein thrombosis can kill you, because if the clot gets out into the lungs and clogs the small capillaries out in the lung, can actually cause rupture of the blood vessels, and they're connected very closely to the alveoli, and then air leaks out into the space around the lungs, and the lungs collapse. And if your lung collapses, if one collapses, you're okay. You're not gonna die, because you still have one to oxygenate your blood. But if you're very unlucky to have both lungs collapse, you're dead immediately. There's nothing anybody can do out in the field to get your lungs inflated fast enough that you're gonna survive. So deep vein thrombosis, that's the killer. You can operate on these blood vessels. There's several things you can do. You can either strip the veins, go in there and actually, you can actually cut them. They don't actually strip them out so much anymore, but they cut them down here, cut them up at a higher point, and then wrap them really tightly, and the endothelial cells will, over time, will stick together and close the veins down. They used to go in and strip them out, but they did more harm than good because they damaged other blood vessels in the area. The vein that is going from your ankle and all the way up your leg to the groin region, they do go in and actually strip that out if you need coronary bypass surgery, because they'll use that as grafts to bypass your coronary blood vessels. But they won't use something like that for coronary bypass. They want a good-looking vessel to do that. The other thing is they can inject chemicals into the intact vein that will irritate the endothelial lining, then wrap it real tight, and the vessel will close down again as well.
So the varicose veins solely due to incompetent blood?
Mm-hmm. Usually you inherit the genetic tendency, so if your mom has it and you're a female, you're probably going to get it. The guys can get varicose veins as well. You have them and they suck. If they suck, then if there is sucking, that's a good thing. No.
Well, they're not sucking. No. That's the problem.
If they're painful, yeah, they're not sucking. You need to do more leg exercises. You need to join a ballet class. Ballet is the best things for varicose veins. It doesn't cure them.
Right on it.
But the exercises, the tendus and the plies do wonders for strengthening the muscles of the leg, especially those tendus. Okay, if you look at the NBA basketball players, especially the tall, skinny ones, usually if you look at their legs, you're going to see humongous varicosities, some the size of golf balls. First time I started paying attention to that, I was like, oh my God, didn't realize that professional athletes would have this problem. But they also have very long skinny muscles and very long bones that these blood vessels and muscles have to stretch across. And so they may be just a little overstressed. The muscles obviously are good enough to compete professionally in the sport, but they're just not good enough to prevent the varicosities. But obviously they're not bothered by the varicose vein. And I'm assuming you're bothered because it's burning and tingling. Oh, well, that's cosmetic then, forget it. The problem with doing something about this cosmetically is if you close the superficial veins down, it means you only got your deep veins to transport blood away from your lower extremities. That puts more pressure on them and increases the likelihood that if blood's going to pool on them, you're going to get deep vein thrombosis. So I think I would rather have ugly looking legs than have an increased chance of deep vein thrombosis. Okay, so pie chart. If you look at it, everything that's kind of reddish, that is on the arterial side of the circulation. Only about 30-35% of your blood is actually in the arterial side of your circulation. The rest, the 65 to 70%, is somewhere in your venous circulation. So pulmonary veins, technically this is oxygenated blood, but it hasn't reached the heart. It's not going systemically, so it's really part of the venous system. The majority of your blood is going to be located in these medium-sized veins and venules. And you're going to have a lot of blood that's in your GI tract, so liver and gastrointestinal system. The large veins, like your vena cava, will have another 18%. So most of your blood is in this capacitance side of the circulation. Okay, question for you. Let's just do it, no clickers involved because I have to restart the clicker software. So the action indicated by the arrows is skeletal muscle pump. true. Yes. The valves are not present in Benioff and large bay. True. Not true. The heads that are going like this, are you saying they're not true or they're not present? I'm not sure. Okay. Valves are not present. This is a true statement. Valves are not present in Benioff and large veins. Medium-sized veins in the upper and lower extremities have valves. Yes. Okay. And incompetent valves can cause phlebitis. Yes. So all of the above are true. That's your best answer. So take a break, and I will restart the software, and we can use the clickers again.
Do you have a quick person that we can I put it about the dilation. No, it's on the other. Why isn't it a distribution? What is the distribution of She said if it is it a distribution if it has an external elastic and no. So but what is the distribution?